Thank you very much for the invitation and the opportunity to give this talk about HPV infection, latency, and apparent viral clearance. My name is Anne Hammer, and I am a gynecologist, but also an associate professor at the Department of Obstetrics and Gynecology in Denmark. So these are my disclosures. So I'd like to start my talk with describing or touching base on this figure here, which illustrates a population-based natural history model. I think many of you already know it, but very shortly, it depicts the natural history model, where you can see the blue, which reflects the HPV prevalence by age. The green is the precancer, and red is cancer. And it's very clear that there's a rapid incline in the prevalence shortly after sexual debut, and then the prevalence rates declines as women ages, leveling out in the older age group, with some variability across countries though. About 10 to 15 years later, after the first peak in HPV prevalence, we see a peak in cervical precancer rates, and then a bit later we see a peak in cancer rates. So what we know for now, and there's no debate about that, is that women who are persistently HPV positive or high-risk HPV types have a higher risk of progression to precancer and cancer, while we also know that women who are negative on the cervical swab for high-risk HPV type have a very, very low immediate and 5-year risk of developing precancer and cancer. So these findings have obviously paved the way for HPV-based screening across many countries. We also know that women and men who have had new sexual partners have a higher risk for HPV detection at any age compared to women who have not had a recent new sex partner. So I also like to share this very pragmatic figure here, which is illustrating the within woman time of HPV infection. And on the y-axis, you see the viral copy number, and then the x-axis, you see time. Down here, I have highlighted that the woman has had several swabs taken and whether there's viral shedding and virus presence. Up here, we have the viral copy number in red, and the dotted blue line is the detectable threshold. So once a woman is exposed to HPV and is acquiring HPV, usually the HPV copy number rises and surpasses the detectable threshold, which results in the test being positive if collected. At one point, usually within 1 to 2 years, the woman would gain immune control, resulting in a drop in the viral copy number, which then is below detectable threshold, resulting in a swab test testing negative. So here we cannot say for sure it's latency, at least it's lack of detectability. But what we also know is that, later in life, the viral copy number may exceed the detectable threshold again, resulting in a test being positive. And I'm going to come back to this a bit later. But these findings clearly indicate that HPV detection is dynamic. 90% or 80 to 90% of HPV infections become undetectable within 1 to 2 years. But whether the undetectable infection really reflects clearance versus viral persistence below detectable levels or even viral latency is a bit unclear. We also know that about 10 to 20% of HPV infections are actually redetected after, quote, apparent clearance. So when we look at it from a woman perspective and also from the clinician handling the cervical screening, the woman can either have HPV detected or not detected. And the source of why a woman has HPV detected may vary. It could be that she actually acquired a new infection, but it could also be a redetection of the low-level infection I showed before. It could be a viral reactivation of a latent infection. It could also be deposition from a recent sexual act, or it could be that the woman's actually harboring a lesion in the anal canal, resulting in autoinoculation. On the other side, women who does not have HPV detected, we cannot know for sure if she completely eradicated the viral infection. We don't know for sure if it's because of sampling error or testing error, or if it's simply just a low-level chronic infection that has no clinical implications, or if it's latency. And right now I'm going to focus on this part over here on the left, which can be put into one group of redetection of a previously acquired infection, and I'm going to come back to this. So first of all, how common is redetection actually? So this study is from 2010, so already 14 years old, but it's very clear when you look at the specific types that the cumulative risk of having a redetection is actually increasing over time. So for 16, as I've highlighted here, we see the proportion of infections reappearing by 12, 24, and 36 months. So it's about 11% of redetection that occurred, and for 6 it's even higher. So it varies across genotypes. So what we don't know is still, does redetection in this group actually reflect viral reactivation or autoinoculation, as I've told before. In this figure here, I've illustrated 2 cohort studies, the Ludwig McGill cohort from Canada and the HIP study from Baltimore. And in those studies, you can actually see that in women aged 18 to 60, that 10 to 15% had actually HPV reappear. And in the HIP study, it was also estimated that 13 to 20% of new detection were attributed to recent acquisition, where it was 72% that could be attributed to redetection of a previously acquired infection. And this is likely because of, the higher proportion here is likely something to do with age, because as women get older, they have accumulated more lifetime sex partners. But it clearly indicates that redetection of a previously acquired infection is not that uncommon. In the same cohort study from Baltimore, we did a study a few years ago where we looked into previous and recent sexual activity. So on the y-axis, you see here the cumulative HPV detection, and on the x-axis, you see time since enrollment. We then categorized women into 2 groups based on their previous or number of lifetime sex partners, so 5 or more, or below 5. And you can clearly see that women who have had 5 or more lifetime sex partners had a 2-fold higher risk of having a new HPV infection detected compared to those that had fewer. What we also looked at was whether they had recent sexual activity. And you can clearly see that the 2 lines are quite on top of each other, meaning that there is no real difference in the risk of new detection here, depending on recent sexual activity, which would indicate that even among women who are sexually active, the new detection is likely not contributed or attributed to the male deposition from a recent sex act. We also know from this study by Strickler, it's almost 20 years old, but we look at HPV detection by immune status. So here on the left side, we see sexually active, and the right side sexually inactive individuals, and then stratified by HIV status, but also by CD4 cell count. And it's very clear on the left side that among sexually active women, the risk of having a new HPV detection is increasing the more immune suppressed a woman is. And when we then compare the 2 groups, the sexually inactive versus the sexually active, we might indicate that the excess risk in sexually active versus inactive women may be attributed to the proportion of acquired versus previously acquired infections. This study here looked into renal transplant recipients and then tested for cervical HPV infection before the procedure and then after. And as I highlight here, you can see that the prevalence of HPV infection increases from 19 to 31%, which would suggest at least some kind of reappearing infection for whatever reason, whether it's viral reactivation or simply redetection of a low-level chronic infection, it's unknown. But it's more likely that these are the causes than a recent acquisition, given that she has had major surgery recently. Most recently, we did this study here, published in BMJ, and I've added this slide because I think it's also important for clinical management here. So this figure here illustrates the cumulative risk of cancer among 2 groups of women. Both had SIN2 detected, and then they were followed over time for up to 20 years using registry data. The red line indicates those that underwent active surveillance, meaning they attended regular follow-up visits with gynecologists with colposcopy biopsies every 6 months for 2 years. And then they did not have a excision performed because they regressed. The blue line indicates those that actually had an excisional treatment performed, either because they wanted that immediately or because they progressed to thin 3 during follow-up. But the figure clearly illustrates that the women who underwent active surveillance and did not have the lesion or the underlying HPV infection removed had a sixfold higher risk of developing cancer on the long term compared to those who had the lesion and the underlying infection removed. So this would indicate that there is at least something to do with an undetectable infection being risky over time. The next question is then, is HPV clearance really feasible at all? And that's a really, really difficult question to answer because it's nearly impossible to confirm viral clearance and also to confirm latency. We did a study a few years ago where we did extensive tissue testing among women who had a hysterectomy due to benign disease. And in that study, we actually found focal HPV detection in women who actually were negative on cervical testing, cervical cytology testing. So we did extensive testing in 2 patients, and here you can see the figure on patient 1, where we sectioned the entire cervix of that woman in 186 sets that underwent separate HPV testing. And among those 186 sets, 14 were positive for HPV, mostly HPV 18, but one slide was also positive for HPV 53. In patient number 2, we did 242 HPV analyses on these 242 sets, and only 2 sets were positive for HPV, and only one of them we were able to identify the genotype being 31. So in this study, it was less than 1% that were positive, but it clearly shows that there is molecular evidence that HPV can remain in the cervical tissue without being detectable in screening, suggesting what I told before, that there is something to do with an undetectable infection. It doesn't necessarily mean that the cervix is not infected. The next question is then from a clinical perspective to inform patient, but also to inform future studies, is what the extent of HPV latency potentially is. So we used our data on 100 women who had the surgery due to benign disease, and then we selected the women with a history of any kind of cervical dysplasia. So we grouped them into low-grade disease, untreated, previous high-grade disease, untreated, and then high-grade disease that had been treated. And we found here by group, we categorized women low-grade in the 3 groups, as I just told. And then we looked into active infection, meaning that they tested positive on the cervical smear, or a latent infection, meaning that they were negative on the cervical smear, but the HPV was detected in the tissue, and then no infection, meaning that either or were positive. And you can clearly see that there is a big bunch of latent infection in all groups, but mostly in those who had a previous history of dysplasia but no treatment, meaning that if you undergo treatment, there is likelihood of at least moving some of the reservoir of latent infections. So this totalized to 50% of the women who underwent testing had a latent HPV infection detected, but that equalizes only to 4.4% of sets being positive, meaning that it's very focal. And HPV 16 was, not surprisingly, the most prevalent type we found. Being a clinician seeing this patient, I also see clinical findings supporting a latent state, or at least an undetectable state. And that is, we see women who enter our clinic and have a new HPV detection, even though they don't have sex. And then after transitioning from cytology to HPV-based screening, we have a lot of women who have had decades of negative cytology tests, and then they're suddenly positive. And then the new detection in older women without a new sexual partner, which is also somewhat surprising. So this leads me to this model, which was proposed by Gravitt and Weiner in 2017, where we look at the within woman HPV natural history instead of using population-based data. So here we start with a positive test, which then can go on to quote clearance, resulting in a negative test, or it could be that she develops a persistent infection resulting in the development of precancer or cancer. But it could also be that the positive test is being controlled by immune system, resulting in a negative test because there's no longer virals being shedded. On one way, a woman could then go from uninfected to being positive again via new acquisition or reinfection. But it could also be the other way around, that when a woman has a controlled infection in the cervix that is not detectable, that she at some point during her life loses immune control, resulting in viral reactivation or at least redetection of a previously acquired infection, resulting in a positive test. So I think we need to think a bit more nuanced about this at the woman level, but also because it has some implications for clinicians, but also our epidemiological studies. So in the International Papillomavirus Society, we have been working on a consensus statement on this subject for quite some time now. The simplified natural history model is up here. It's the one I showed you in the beginning. We go from a healthy cervix that acquires HPV, and then it's HPV affected, and then it goes back again when there is clairance. In the updated natural history model, we propose a more nuanced model, and yet a bit simple, more simple than the one I showed before, that where we also acknowledge that we cannot know for sure that an infection becomes cleared and that a new infection is acquired. But we really need to acknowledge that over here, that a woman may go from having a detectable infection to having an undetectable infection due to a reversible increase or decrease in viral load for whatever reason that might be. So the next question is then, why is this so important? Why do we need to rethink what we know about the HPV natural history? And why is it important to distinguish the source of infection, whether it is a newly acquired infection, whether it is redetection or viral reactivation or so forth? Well, from an epidemiological point of view, there are certain biases with all study designs, but when it comes to HPV studies, we need to acknowledge that when a woman enters a study and at enrollment has an HPV test collected, and turns out to be negative, or it could be positive, we don't know her previous screening history or testing pattern. So we are unable to confirm that the negative test means that she is truly HPV naive. On the other hand, we don't know that if she is positive at enrollment, for how long has she been positive? We don't know either. And the unknown test status between study visits also proposes an issue, because if there is 1 year between tests and both are positive, it is by clinical point of view would be determined as a persistent HPV infection. But it could be that she would have been negative had she undergone testing in between. We don't know. And on the right side, we don't know the test status after she ends the study. So over here, you can see the original cohort study interpretation of these various testing patterns. And it's just to summarize that there are some issues with this. From a clinical point of view, there are also very important clinical implications. For example, what we know about the natural history model help to inform health prevention strategies such as screening and HPV vaccination. And it is important to understand that if a woman tests positive on HPV testing at the age of, let's say, 45 or 50, it may not be that she has acquired a new infection. It's more likely that she has a redetection, meaning that had she received a vaccine 2 years prior, it is not that likely that would have prevented her from testing positive again. So it has an important implication regarding our correct estimation of the impact of HPV vaccination on cervical cancer burden across all ages. And that has been proven in some studies that actually show that if you do not allow for viral reactivation of latent infection, you might overestimate the potential impact of the vaccine on the cancer burden. It's also important in terms of screening, because models that do not consider latency, they predict a greater reduction in HPV infection compared to models that do not include a latent state. So that is important as well. And also being a clinician, I do think it has significant clinical implication on clinical counseling of women attending cervical cancer screening, particularly now where we use HPV-based screening, because many women ask about source of infection. And I'm not saying that we should distinguish between the source of infection, but we do need to acknowledge that women would want to know that it's not because of infidelity that she suddenly tests positive. It could be that it is simply a redetection of an infection she has acquired at some point in life, whether it is autoinoculation, reactivation, or whatever, doesn't really matter, but she needs to know that it is likely a redetection. The second part is that it does matter in terms of lifetime versus 5-year risk of CIN3+. So we do know that the immediate risk of cancer and CIN3 is very low if you test negative. But women should know that they have to continue screening, because if she suddenly tests positive, her risk changes. And so far, we don't have any information on whether risk of cancer varies by source of infection. So that is something we need to look further into in the future. For example, this study here is important for patients to know, is that there is a higher risk of CIN2+ or CIN3+ in women who are negative on screening, but with a previous history of HPV. So here you can see on the left, women who had previous HPV testing only, in the middle, previous cytology only, and on the far right, women who had previous HPV and cytology. And as you can see, I've highlighted with the red arrows, there is a marked difference between women who had a previous HPV positive test in yellow versus those that had a negative test. So there's a marked difference in risk, which suggests that in screening, previous HPV positivity matters a lot for her subsequent risk. Then there are certain clinical scenarios I've included as well, because I think it is important that we inform our colleagues in the clinic to better inform patients about source of infection, but also the importance of screening. So for example, this one is a woman who says, my test is negative and I don't have a new partner. Do I need to continue screening? And if we look at the first population-based natural history model, the one would likely say, no, your risk is very low, because if you don't have a new partner, why would you then acquire an HPV infection? But the correct answer, when you looked at a more nuanced model, would be that yes, you should continue to be screened regularly, because a negative test is associated with a low immediate risk of CIN3+, but risk changes if the next test is positive. And in the latter case, it is also important to acknowledge that her risk is very different depending on her previous screening history and her previous history of, for example, CIN2+ or CIN3+. The second one is also a thing we often see is, I've never had an abnormal screening test. Now my test is positive. Why can that be? And the most, based on the first natural history model, would be that you likely got a new infection. You acquired it from somewhere. But the more nuanced model implies that we might rephrase that answer to, well, the positive test may simply reflect redetection of an infection which you acquired earlier in life. For a short period, you have lost control over the infection. What matters is that you regain immune control. And that is what we see in many studies, is that what matters is that she goes from positive to negative. So we need to continue follow-up to ensure that we detect in due time. So just to sum up, what we know so far is that HPV is able to hide in the cervical epithelium without showing any evidence of disease, no viral replication, and no HPV detection on exfoliated cell samples. And so far, it may seem like all high-risk HPV genotypes seem to be able to establish latency, and that HPV detection can occur as a result of acquisition, autoinoculation, or redetection. And we also know that redetection or reactivation is associated with immune suppression. What we don't know so far is that how much of new HPV detection occurs as a result of redetection versus the other sources. We also don't know for sure whether risk of CIN3+ vary depending on the pathway to new detection. So we don't know if women who had viral reactivation of a previously acquired infection have a significantly higher risk than those who had a new acquisition. And to explore this would require extensive testing at the type-specific level, but also detailed information on a woman's sexual activity throughout her life. We also don't know for sure if latency is site-specific, age-specific, or sex-specific. Most of what we know so far about HPV natural history is based on the cervix. It would seem plausible that we would see the same thing in the anus or in the vagina or in the vulva, but we don't know because there is not much evidence out there. We also don't know if latency is only seen in a subgroup of infected individuals or if it's simply a thing the virus does, like herpes virus, for example. In our study, we found 50% having a latent infection, but we also have to acknowledge that in that study, we did not section the entire cervix in all individuals. So it could be that we simply haven't looked enough. And then we still don't know how latency is established and maintained, how the immune system kicks in here. So with that, I'd like to say thank you very much for your attention. And I'd also like to acknowledge all my co-workers through the years, and particularly the IPVS Working Group Steering Committee and the Clinical Working Group. Thank you very much.